Well, good morning. Welcome everyone to this session, or I should say good night or good afternoon, depending on where you are. This is a section where we're going to be talking about innovations in implementation research, launching a session around the journal supplement on that topic from Health Policy and Planning. I'm David Peters. I'm going to be the moderator for this session. I am a professor and chair of the Department of International Health at Johns Hopkins Bloomberg School of Public Health. I am also the chair of the Alliance for Health Policy and Systems Research, which is the co-sponsor with the journal for this this journal issue. Let me introduce briefly about the Alliance and its role before moving on to the rest of our session. The Alliance, which is housed at the World Health Organization, is an organization that is set up really to help develop the field of health policy and systems research, starting back in the late 1990s. It does this by generating health policy and systems research, really to try and build the knowledge areas in neglected and important areas, particularly to address issues of health equity. It also serves a role to increase demand and use of knowledge for health systems strengthening, as well as building capacities of researchers, particularly in low and middle income countries, and policymakers and other users of health policy and systems research. The Alliance and the journals and the Health Policy and Planning sponsored this journal supplement, really focusing on innovations in implementation research, which is a fast evolving field. Over the last 8 to 10 years, I would say, the Alliance has done really a remarkable job in helping to shape and define the field of implementation research, but also to sponsor capacity building and innovative applications. And this journal is an example of one of those, of that type of work. It shows an example of the vision of many people around the world pulled together by the Alliance and helping to drive really cutting edge thinking and doing in health systems research, or policy and systems research. And this journal shows really a good display of a large number of researchers, practitioners, researcher practitioners, as well as provides examples of a way in which we learn from each other, and really is a good demonstration around the types of uses of this research. So in this journal, there are a dozen research articles and 2 commentaries. And what we're going to hear is just a little taste of some of the work that is put into this supplement. We will hear about some real innovations and adaptations in methodologies, but also around the approaches for how you would use research in different places, developing theories and applications. Some of the articles are really going to discuss the governance of research, as well as some very interesting types of implementation problems. They're going to be they are in a wide variety of settings, a wide variety of problems, and you get to see the degree in which this research is fit for purpose of the problems and where they are in terms of implementation of policy and practice. So I'm going to keep the introduction short so that we can move on to hearing from the authors. I would remind you to please put your questions into the chat, and we will get a chance at the end of the session to be discussing them. So first, I would like to introduce Kabir Sheikh, one of the thinkers and editors behind the scenes of putting this supplement together. He is a policy advisor and working at the Alliance for Health Policy and Systems Research in Geneva. You will know him, of course, in many other, wearing many other hats, himself as a researcher, educator, planner, practitioner. Previously, his leadership roles chair of the Health Systems Global, and delighted to see a good friend putting together this type of research. And let me turn it over to you at this point, Kabir.
Thank you, David, for the very kind words and also for the great introduction about the origins and the need for a supplement like this. And let me take the opportunity in the limited time we have to spell out a little bit more about the supplement and the overview and why we decided to move forward with it. I'm going to share my screen now. I hope it all works. Okay, so good morning, afternoon, and evening also to everybody present. I know that people have joined from all over the world, and I see we have quite a lot of people on the meeting already. So I'll just start by contextualizing the broader issue of implementation, why we decided to focus on implementation research. As before getting to the importance of innovating in implementation research, it's helpful to put this in the context of growing interest in implementation processes per se. We know that in global health, there's a growing recognition of the importance of understanding implementation processes better. And there are different reasons for this. The most obvious and the big one is that there's a growing recognition that implementation is a key factor in determining program outcomes and in shaping the success of broader health policies and reforms. And needs to go beyond just an understanding of management failures to actually understanding how implementation processes play out in real life. But it's also worth noting that the recognition of implementation as a distinct and important area of inquiry is not entirely new or recent. And this quotation from one of the seminal texts in implementation studies from Michael Lipsky from 1971 provides a different reasoning around the importance of implementation. It suggests that it's as important to tackle the messy realities of real-world experiences as to focus on devising stratagems and plans in places that are often distant from their ultimate beneficiaries. The quote refers to governments, but of course it could be extended to all publicly oriented policies and services. So with the growing interest in implementation research, we've observed that it's beginning to become more prevalent as a core aspect of global health programming. We're also seeing that implementation research is now being supported by some country governments. It's being taken to scale, although not necessarily at scale already. And there's more and more implementation research happening in the international health context in countries. But what are we actually learning from these experiences? And how are we using those learnings to bring about improvements in the field at large? So the reasoning and the thinking behind this special issue was that for an applied field such as implementation research, evolution must take place by documenting and recording innovations in research practice. And this was really the impetus for conceptualizing the special issue. And in particular, it was felt to be important to learn about innovations occurring in low and middle income country context, because that is the context where implementation research has the greatest potential to have impact. We issued a joint call with the Alliance for Health Policy and Systems Research and Health Policy and Planning about a year ago in November 2019, and we had over 80 submissions. And this supplement is the end product of that call. So the supplement is now live on the Health Policy and Planning website, and all 15 papers, the editorial, 2 commentaries, and the 12 research articles are all open access. I can't, of course, describe all of them, and we look forward to invite you to read all of the papers. But here is a map of some of the key innovations showcased in the articles. And as you can see, there's a sort of an equal balance between innovating in the methods and design of implementation research, which is the top 6 papers, and on the bottom side, experiments with broadening stakeholder engagement around implementation research. So there's quite a diverse range of innovations around the method side, from more effective use of theory to reorienting evaluations to focus more on learning, to using policy analysis approaches to unearth hidden dynamics in implementation. And on the other side, other papers are focused on innovating with engaging health system decision makers, communities and users of services, and also working across sectoral divides. And we are delighted to have 3 of the authors who will make presentations later in this session. In addition to the 12 articles and the editorial, there are also 2 commentaries, one by country policymakers who have played roles themselves in institutionalizing implementation research in their countries, and another by the senior leadership of the World Health Organization on the significance of implementation research in promoting cultures and practices of learning in health systems. So in terms of the themes that really cut across the supplement, almost all the papers demonstrated a strong focus on supporting change in policies and practices, and often through embedded research practice. The other common thread was on advancing change by a focus on learning, whether in the short or the long term. And the mix of papers also highlighted the transdisciplinary character of implementation research, defined by the real-world implementation challenges that it seeks to address, and using a range of methodological inputs to analyze and tackle them. So what we take away at the end of the summary is that this supplement has showed that the value of implementation research is twofold. Many of the papers showcase the value in improving the implementation of programs and services by addressing specific contextually determined problems and bottlenecks, and that certainly remains a central contribution of implementation research as a field. At the same time, not all types of implementation research enable change through easily actionable solutions and prescriptions. As some of the other papers show, underlying systemic issues, power politics, and the dominance of specific narratives often shape and define visible implementation challenges. And the value of implementation research lies not just in improving implementation, but also in raising critical questions about the appropriateness of the policies and programs in the first place. We also take away that it's important that implementation research should not be constrained by its territorial boundaries, but continue to embrace diverse methodologies and address different questions about implementation, the full spectrum of questions about implementation. We are very happy to have had the support of the leadership at WHO for the special issue, and also much more broadly for advancing the implementation research agenda within WHO, for which this supplement is one step. The chief scientist of WHO is going to be talking later in the session. But here also is a quote from the Deputy Director General of WHO, where she highlights the importance of implementation research as a way for country health systems to become more self-reliant in their learning abilities, including in the context of emergencies such as COVID-19. And I'll close with a final slide to acknowledge and thank all the people, the colleagues at the Alliance, as well as at Health Policy and Planning, who are part of the team effort of producing this supplement, apart from James Hargreaves and myself. James is going to be speaking next. And of course, a big thank you also to all the authors who put in their time, not just the people who finally made it to the supplement, but everybody who has contributed submissions to the special issue and to the call. And a real reminder to us that implementation research is a big issue, which commands a lot of attention and deserves a focus on innovation and taking the field forward. So with those final words, thank you, and back to the chair. Thank you so much, David. Okay, I see that we are having a little problem.
Can you hear me okay, Kabir? It's not.
James, it seems that David is experiencing some technical issues. So I'll just take a minute to introduce you instead, and I'm sure that David will join us shortly. So delighted to have James Hargreaves speaking next, and he is a professor of epidemiology and evaluation at the London School of Hygiene and Tropical Medicine, and the lead editor of the supplement together with myself. He is the founding director of the London School of Hygiene and Tropical Medicine Center for Evaluation, specializing in the use of pragmatic but rigorous mixed methods for the evaluation of public health interventions. We're delighted to have James with us, and over to you, James, for your talk.
Great. Thank you very much indeed, Kabir. It's very nice to be here, and let me add my welcome to everyone for the launch of this supplement. I'm going to share my screen. Great. So I was asked to talk for just a few minutes about the state of the art in implementation research, and Kabir has done a very nice job of it, giving you a sense of what's in the supplement, and we're going to hear in a minute from some of the authors who contributed to it. So I'm not going to talk directly about the supplement, but I'm going to raise the idea that perhaps what the supplement represents is a a grand convergence in the field between the ideas of implementation and research. And I'm going to explain to you what I mean by that. I borrowed the idea of a grand convergence from this Lancet Commission, which was published in 2013. It was itself a follow-on from the Investing in Health report, World Development Report in 1993. And in this Lancet Commission, the authors argue for further investments in health over the next generation, which they defined as to the year 2035. And they concluded that over this period, there was the possibility of achieving dramatic gains in global health by 2035 through a grand convergence around infectious child and maternal mortality, through major reductions in the incidence and consequence of NCDs and injuries, and through the promise of universal health coverage. And what they meant by a grand convergence was that with appropriate investment and through the development and implementation of public health programs, infectious child and maternal mortality could be brought from levels currently experienced by the lowest income countries up to those in middle income countries. And by doing so, we would see dramatic gains in global health. The supplement also talks about the importance of an agenda focused on population policy and implementation research. And I borrowed this idea of a grand convergence. This slide is a caricature, perhaps, of how things were a decade or so ago. The real focus of rigorous research was on developing, understanding, and evaluating the efficacy of the tools that we need to achieve these gains in public health and bringing those for programs to use. However, as those tools needed to be translated and shown to be effective in real life situations and then to have demonstrable impact on public and global health, the emphasis moves from research towards the implementation of programs. But perhaps what we're seeing now is a convergence of these two ideas and a greater focus of rigorous research done within, on, and about the implementation of programs. And I see developments in three fields that lead me to come to this conclusion. The first is from the research side and is around the growing development of pragmatic mixed methodologies for the evaluation of programs and implementation. One sees the development of new forms of randomized trials, such as stepwise trials and the random Eastern movement in economics that are used to identify policy and implementation questions. There's a growing orthodoxy and recognition of the importance of rigorous impact evaluation coupled with a process evaluation that studies what's needed to achieve implementation in practice, how clients respond to interventions, and what contextual factors affect these. And there's been the development of a range of non-randomized methods for impact evaluation that have matured over the course of the last few years. Secondly, we've seen the development of a range of implementation frameworks to help guide both research and programmatic implementation. These include the Consolidated Framework for Implementation Research, frameworks to support the development and description of complex public health interventions, frameworks to support the development and piloting of interventions, and frameworks such as normalization process theory, which is something used in some of the papers of the series, that try and understand and articulate the implementation process itself. And the development of these frameworks has come from many different disciplines and is a growing feature of implementation research. Finally, and my last words, perhaps the strongest theme in the series as a whole is the development from the implementation side of partnerships in practice, embedded research, and a growing focus on understanding and learning within programs. The series is littered with excellent examples of implementation being done hand in hand with research processes to try and understand barriers to and facilitators of better program implementation. And I think it's the combination of these three forces, the growing role of pragmatic mixed methods, the growing use of implementation frameworks for understanding implementation, and the growing commitment to implementation research partnerships in practice that's taking forward the field and is the state of the art today. And I hope to see continued development of that alongside the types of papers we have in the series. Thanks. And with that, I'll hand back, I hope, to David if he's rejoined us as chair. Otherwise, perhaps to Kabir.
I am back. Thank you very much. And sorry to have missed the beginning. There was a network failure, but it seems to have come back. An implementation problem that won't take much research, I hope. But thank you for that overview and really trying to position the type of research shown here in terms of where it is moving the field. With that, I would like to then turn the speakers over to introducing the next speaker, who has been a long-standing leader in the field, both in terms of thinking, practice, doing research, and delighted to say also the chair of the Scientific Technical Advisory Committee of the Alliance for Health Policy and Systems Research, Jeanette Vega, who's currently Chief Medical and Innovation Officer at the Red de SALUD in Santiago, Chile, who is as I mentioned, a well-known public health expert and thinker. So with that, I'd like to turn it over to you, Jeanette.
Thank you very much, David, and also to the previous speakers, and in particular to Kabir and team that have done such a wonderful job in putting together this journal. First of all, I want to tell that I will focus my remarks on the implementation research in low and middle income countries, and in particular what we need to make implementation research mainstreamed and made routine. In my opinion, this is the critical step if we are really going to inform decision making on an ongoing and systematic basis. To understand what is needed for institutionalization of research, we need to get a good grasp of what we would like to see. First of all, we'd like to see contextually relevant implementation research, and also that this research is generated in collaboration with decision makers and connected, I would say, to the country priorities. And secondly, we'd like to see from the researcher point of view that the research, it is in fact applied to inform decisions and policies that will contribute to stronger health systems. In order to achieve this, in any country, we need to have some prerequisites, I would say. And basically, I would summarize this as having capacity, having committed funding, and having co-production of this research. In terms of capacity, we need, of course, to have a critical mass of trained researchers, but also institutions that have the capacity to manage research grants and capacity of the users to use this research. And also, we need to have researchers understand that the timing of implementation research, if it's going to be useful, is very different from the usual timing of researchers. Policymakers and politicians make decisions with or without evidence. And if we want to be relevant, we need to align to the times of the policymakers. A good example of institutionalization of research is, of course, Thailand. They have trained implementation researchers, including scholarships, providing a scholarship to world-class universities for a long time. But not only providing a scholarship, but providing the researchers an institutional home to work and to grow when they return to the country. And that's why I think Thailand has been able to play a major role in providing evidence, in particular in the case of health reform processes, profiling the experience of Thailand. Another example, of course, is the Consortium for Mother, Children, Adolescents, and Health Policies and System Strengthening in Ghana, which is a more recent initiative in developing capacity. The second area, of course, is that we need to have committed funding. And this is a problem because in most of the countries, not necessarily the funding for implementation research is there. There is funding for science usually, and funding for projects that are demonstration or proof of concept projects. But funding specifically for the area of implementation research is scarce. So it's very important that we do try to make sure that we convince countries and policymakers and funding institutions of the need to fund this type of research that is particularly relevant for countries. A good example, of course, is, as I said, Thailand, but also India's National Knowledge Platform, that it's a very good example of countries that have made such investment. And finally, applied research needs mechanisms to facilitate that researchers and implementers collaborate and basically are able to leverage the strength of both groups. And this is also a key issue. And I think that the University of Gondar in Ethiopia, that has worked very closely with the Ethiopian Ministry of Health to manage research programs that are basically of national interest or a priority, is a very good example. And in the process of doing this research, they build skills in engaging researcher implementer teams to make sure that they both understand each other. So in conclusion, I would say that we need all these three prerequisites to click if we want implementation research to be in fact of relevance and to be institutionalized. Capacity, co-production, and committed funding. But they are not sufficient by themselves. Again, as in many fields, a critical variable is leadership, to put forward a vision in the country of the need to have implementation research, and also not only to have the vision, but to make sure that within countries there is a new generation that is able to have and share this vision and use, in particular, policymakers, future policymakers, and use and be willing to use the research generated to make decisions, or in other words, what it's usually said, to make sure that the decisions are made with some basis of evidence. So by this, I will conclude. And again, thank you. And in particular, my colleagues that came before myself. Thank you.
Thank you, Jeanette. That was a very thoughtful perspective on the use of implementation research, really to support leadership in a country, again, with those 3 C's of capacity, co-production, and committed funding to help be able to do that. We're going to shift now to one of the authors who has who's taking the implementation research at a different setting, really from the bottom up, looking at team-based primary care for non-communicable disease in locations in South India. And I'm pleased to introduce Dorothy Lall, who is a faculty member at the Institute of Public Health in Bengaluru, India, and currently studying her PhD at Maastricht in the Netherlands. Please take it away, Dorothy.
Thank you so much, and thank you for this opportunity to present a few thank you for this opportunity, and thank you for allowing me to present a few reflections from our experience in implementing quality improvement interventions. So in this paper, we present the implementation process of a package of quality improvement interventions for the non-communicable disease services at 3 primary healthcare centers in rural South India. Healthcare in India, as some of you may be aware, is structured into primary, secondary, and tertiary levels of care. And primary health centers, or the PHCs, are the mainstay of government-funded primary care provision in rural India. Well, there are several gaps in the way we organize care, especially as traditionally, like most other health systems, we are geared to acute episodic care that does not respond adequately to the needs of chronic care. So the interventions were co-developed with implementers and were designed to address gaps that were identified from a situational analysis. The interventions were a redesign of the workflow, and that in that process, we identified tasks. These tasks were then redistributed among the team members. Another intervention was introduction of medical records, which are not something that are usual at primary care centers in India. And the last was to involve the community health worker for follow-up and reminders at people's homes and in the community. I'd like to share 2 points of reflection, one with regard to the methods we used and one with regard to what we found that perhaps also reinforces the choice of the methods. The implementation research design we chose was quality improvement designs, and co-designing the intervention with the implementer was an enriching experience for us as researchers. We maintained an outsider position and could appreciate the advantage of the design in allowing iterations, flexibility to respond and adapt to the local situation, to the interest and priorities of the implementers themselves. It also allowed us to focus on why and how things were working or not, and not just on whether they were effective. We tried to capture some of this complexity, which was important in the implementation process, and used 2 theoretical frameworks to help us to define, first of all, what context meant, and then to make sense of what we were seeing. So we used the consolidated framework for implementation research and the model for understanding success and quality improvement specifically, and this guided our data collection and analysis. Falling back on these theories, we knew what to look for, or we had leads on what to look for. And the frameworks also enabled us then to gain insights that are valid beyond this setting alone. The second reflection is about what we found. So all 3 PHCs had very different outcomes of implementation. At one PHC, things were implemented but reverted back after a few months. At another, the team got transferred and therefore implementation did not happen. And at one, most of the implementation was successful. In redistributing the tasks, we had aimed to deliver team-based care. And we found that the main barrier to this were the existing hierarchies within the team, doctor being at the apex of this hierarchy. And the main facilitator in the center that it did happen in was team cohesion and the relationships among team members that we found. We found that facilitating team-based care or even prioritizing quality are largely dependent on leadership. So leadership that's relational can really facilitate team-based care and the quality of services for chronic care. This is coherent with the theories that we used that also hypothesize a central ubiquitous role of strong leadership. What we concluded with is that we probably need to expand the role of primary healthcare centers beyond what is currently framed in the national program for NCDs. We need to focus probably on developing leadership for primary care teams in India. And also perhaps there's a need for QI teams that can externally facilitate and support change processes, helping teams to reflect on the organization of services provided. And QI designs are good and fit for testing local solutions relevant to the local context. Thanks once again for the opportunity, and back to you, David.
Thank you very much. It's very important to see the level of work really at the ground level and getting some both specific problems solved, but also some more generalizable solutions about how do you address underlying issues. We're going to move then next to Mary Adam and jump continents to Kenya, where she is the Director of Maternal, Newborn and Community Health at the Kijabe Hospital, and really going to continue on that theme of frontline provision, but taking a different approach, looking at human-centered design and linking it to community trust building. Over to you, Mary.
Thank you so much, Dr. Peters. You know, welcome to our participants from across the globe. And as I begin, I want you to ask yourself a question. Who's the one person in your workplace you can trust to get things done? How did you build that trust? We describe using human-centered design to train community health volunteers to build the trust of their stakeholders. Now, we all know trust is indispensable for health systems to function. And this is where human-centered design and implementation science become the best of friends. Both are relational processes. And trust is required for relational processes to actually work. So I'm going to frame two questions about how human-centered design helps implementation science. Number one, human-centered design provides a great platform for engagement of all kinds of participants and stakeholders. Human-centered design has great strength in growing understanding of the actors through building empathy. It builds skills in practical problem solving, and it provides a safe space for trial and error, for using iteration in building and testing action plans. But human-centered design is pragmatic. It's primarily a practice framework, not a protocol rooted in theory. Its commonest use in health systems has been more on product development and process change, leaving it lacking explanatory power and reproducible measurement. Which moves us to question two: how does human-centered design leverage behavior change theories? We present our theory of trust building as a case in point. It demonstrates that behavior change theory linked to human-centered design can support measurement and explain sustained engagement. Trust building reciprocity cycles have three building blocks: the common goal, self-interest, and gratitude and indebtedness. And here's what we found tracking 21 groups of community health volunteers in 5 different areas, from rural agrarian to peri-urban slums. Where recurrent reciprocal cycles of trust building were present, there was successful implementation of action plans, and iterative plan, do, study, act cycles for improvement confirmed engagement was sustained. The longer term result was a positive impact across a range of social determinants of health. Where the cycles of reciprocal trust building broke down, everything stopped. So human-centered design processes supported measurement. Human-centered design helped people articulate their self-interest and common goals. And as those mutual goals were achieved, it was only natural for them to celebrate and express gratitude to one another. Because the participants organized and prioritized actions for themselves bottom up, people owned the problems and they developed their own solutions. Human-centered design built empathy, and it leveraged user voice into the health system. It resulted in co-production of knowledge on how to get things done. So human-centered design spotlights user perspective to reimagine and re-engineer health services. Human-centered design linked to theory can support trust building to help the system work. If you want to learn more about human-centered design, I'd invite you to join our organized session on November 25th. Thank you so much, Dr. Peters. Back to you.
Thanks, Mary. That was a terrific example of thoughtful implementation research, really moving the field and actually combining fields together. I'm very delighted to jump continents now to Argentina to introduce Ilona Varallyay. Particularly pleased because she is a DrPH candidate in our own department, and happy to say that I'm also her advisor. She has some really exciting research looking at embedded research models and how they've been applied. So Ilona, over to you.
Thank you very much, Dr. Peters. It's an honor to participate on this launch. So this study sought to understand whether and how one form of embedded IR, works in driving program or policy improvements. And here the key aspect of innovation lies in the who carries out the research. So let me start by just touching on what this embedded IR model entails. 4 key specific features are highlighted. 1, health system decision makers lead the research as principal investigators. And here, decision maker refers to a range of implementers from policymakers down to frontline providers. 2, a collaborative approach to research partnerships, so ideally engaging decision makers and researchers. 3, integrating the research into existing program processes. And then lastly, key to IR, a research focus on issues about program or policy implementation. Our interest in this paper was to understand whether and how these 4 embedded IR features influence evidence to action processes and outcomes across different settings. So to do this, we conducted a prospective comparative case study using qualitative methods, so semi-structured interviews and document review. And we examined 3 specific cases that participated in a small grants initiative for embedded IR. One in Bolivia, which looked at a micronutrient supplement for anemia in children. One in the Dominican Republic, focused on a family planning program. And one in Colombia, focused on the cervical cancer screening program. And given the breadth of IR, I think it's just worth mentioning that these studies focused on understanding really the root causes of a specific implementation problem, rather than, for example, adapting or testing an approach to implementation. So what did we find? Not surprisingly, there was a great deal of variation across the cases in how they operationalized and leveraged these 4 features. A few key findings emerged. For example, central to embedded IR with a proactive engagement and the intellectual leadership by decision maker PIs. Factors that enhanced their ability to drive change included an adequate level and scope of authority over the targeted program, which then allowed them to respond to findings in their own work, the ability to leverage their professional networks to influence other key stakeholders to use the evidence, and then of course, meaningful reflection over the findings in an ongoing manner, which in one case facilitated remedial action in real time as the evidence emerged, such as adjustments to delivery to improve access. With respect to the research partnership feature, 2 of the more successful partnerships were led by strong decision makers who were able to bring together stakeholders with diverse perspectives, which generated new ways of thinking and enhanced problem solving. However, these did not always engage locally based researchers, and here the TA from the grant initiative was key. Also, the fact that the study team members opted into the partnerships contributed to establishing a common purpose, sense of ownership and commitment, helping them advance their goals. And these kinds of details should be considered when promoting these partnerships on a wider scale. Regarding the integration of research and program processes, this occurred primarily to the extent that the decision makers were able to align the two in their own sphere of work. For example, ensuring that the evidence fed into annual budgeting and planning processes, as occurred in one case. We found that for these one-off studies, this level of integration may be adequate, but we expect that this feature will play a stronger role in efforts seeking to institutionalize embedded IR, as has been mentioned previously. And finally, the feature on an implementation focus. We found that by identifying the research topics of concern to them, decision maker PIs helped ensure findings were responsive to their information needs and actionable. Decision makers could then use the evidence directly to implement change. However, articulating the research questions focused on implementation was quite challenging for some of these novice research teams, particularly those that had more familiarity with epidemiological or other health research. And this also has implications regarding the support needed for these processes in the future. So to conclude, our case studies showed that when well supported, these decision maker-led IR partnerships can stimulate the use of research to drive program improvements. This study sheds new light on the inner workings of this embedded IR approach, highlighting a pivotal role for decision makers. We believe this knowledge can strengthen the practice of embedded IR moving forward and help advance wider efforts to cultivate much needed evidence-informed decision-making in health systems. Thank you very much for this opportunity, and back to you, Dr. Peters.
Thank you, Ilona. That's great experience. In the short time we have left, we are really privileged to turn the floor over to Dr. Soumya Swaminathan, a preeminent researcher and leader in the field, and certainly one of the most busy people right now as chief scientist at the World Health Organization. So we're going to move back to Europe and turn the floor over to you, Dr. Swaminathan.
Thank you. Thank you very much, David. I hope you can hear me all right. So first of all, I want to congratulate all the speakers of the session today who have really very clearly laid out the experiences and really the progress that we've seen in implementation research around the world. And we've heard from people literally from different continents, you know, speaking about their own experiences, some from a more academic point of view, but many really talking about the work on the ground that is shaping this field. And I think it's becoming increasingly clear that this field is not only important, but almost essential for the concept of learning health systems and for the improvements in the quality of healthcare that we would all like to see. So I would first like to congratulate the Alliance, as well as all the partners who really worked together on this special supplement of the journal, and also very happy to see that, you know, of the 12 very high quality articles, most of them are led by researchers from low and middle income countries, and most of them are women. So because this is such a field that keeps changing and growing, it's really good really to hear and see all the innovations in implementation research that have been described. And we, of course, as you know, from WHO as well as the Alliance for Health Policy and Systems Research, have been strong supporters and advocates for the embedding of health research into institutional systems in countries. And I think we heard from some of the speakers examples of countries that have really invested in this, have institutionalized it, have built capacity, and how that has really helped them to improve their own capacity for the health systems to deliver and to continuously learn and change and respond. Because we understand, especially from WHO, I have this sensitivity all the time that we produce guidelines, we produce norms and a lot of guidance documents. A lot of it is produced in headquarters for the global audience. A lot of it is produced at our regional offices. But when it actually, gets implemented in countries, it has to be contextualized. It has to be adapted, and it has to be implemented in ways that are most efficient and effective. And this is where I think implementation research really plays a role, because you cannot have a one-size-fits-all way of doing things. Particularly, I think when we're talking about public health interventions, not just simple treatment guidelines or something which you can just adopt and have all your practitioners use that. But when we talk about interventions in primary healthcare, for example, it is so complex. There are multiple interventions, obviously, that are needed to be done simultaneously. So evaluation of these things also then is a complex exercise. It needs this type of mixed methods approach. It needs qualitative and quantitative. It needs your social and behavioral scientists, economists, and others weighing in, as well as academic researchers. So it's really successful only when it encompasses all of these complexities. And that is difficult sometimes at the ground level to achieve, and particularly to embed it within the ministries of health. And I think Jeanette was also raising this very important issue of sustained funding for this, which is also a challenge. But I think we've seen examples of countries that have done it, that have recognized the importance. So the Alliance, as well as the Science Division, will continue to work with member states who are interested and try and encourage others. We've had very successful examples in the past year or so of working with India, with the National Health Assurance Initiative, of working with Ethiopia, with Kenya, with Pakistan. And we hope that, excuse me, we can do this with many other countries. It is clear that this is the time, as we talk about expanding universal health coverage, at strengthening health systems, investing, that countries need to know where they need to invest, and also they need to be able to evaluate the impact of those investments. And so while currently learning may be low on the priorities of ministries because they're challenged with so many issues that they need to prioritize, that very often research goes to the bottom of that list, unfortunately, unless the value is appreciated. So it's clear that, we have champions here, and I don't need to convince this group of the importance, but we need to work together to convince our end users, the ministries of health, the policymakers, the program managers, and also the big global funders of research, and also programmatic interventions, so that this gets built in and becomes really, once it becomes part of the structure, the thinking within countries. I have experienced that happen in India. It's very difficult to break that first barrier, but once it becomes part of that and people start understanding the value, then you get strong support from different partners. So thank you very much for this opportunity. And I once again congratulate all the speakers as well as the chair, David, for having taken us through this session so ably. Back to you.
Thank you very much. And that's a nice way to end, Dr. Swaminathan. This was a wonderful session. We saw a sampling of really a great variety of work from what is a wonderful supplement. Unfortunately, we don't have time for further discussion, but we were able to hear from a wide range of authors, settings, providing really some deep insights in a short period, but with work that's demonstrating considerable impact. We're moving beyond individual problem descriptions to really deeper understanding about solving problems, unpacking underlying causes and influences, and really some good theory-driven approaches to adaptation and learning from different stakeholders. We are seeing here really a demonstration of how to fulfill the potential of implementation research in many contexts, taken up by many different institutions and individuals, and really looking forward to the future opportunity to addressing how to improve health systems using the kinds of evidence that is generated, co-produced, and used in many different ways. So I'm looking forward to future discussions and developments in the field, and looking forward to working on this with you on this journey beyond the conference. And I hope you enjoy the rest of the conference day and the next sessions to follow. So with that, wish you again thanks for all the speakers and for those that are watching, and enjoy the rest of the conference. Thank you.